Good evening. My name is Roxanne Chabot from RBC Consultants. Welcome to another Skin Chat. This evening, we're going to talk about xerosis and skin barrier changes in mature patients, and as well as the implications for skincare recommendation. As speakers this evening, we have Dr. David Goldberg. Dr. Goldberg is Clinical Professor of Dermatology, Icahn School of Medicine in Mount Sinai, Director of Skin Laser and Surgery Specialist, Cosmetic Dermatology and Clinical Research at the Schweiger Dermatology Group. We also have Dr. Michael Gold, who is the founder of Gold Skincare Center in Nashville, Tennessee, and Clinical Assistant Professor at the Vanderbilt University School of Nursing in Nashville, Tennessee. And we'd just like to take a moment this evening to express that our thoughts and prayers are with the families and the victims of the Covenant School incident today in Nashville, which was about a quarter of a mile from Dr. Gold's home. We'd also like to thank our supporters, CeraVe, for making this educational event possible. Before we begin, if you're having issues hearing the webinar, you can listen to the presentation using your telephone. Just select phone call in the audio pane and the dial-in information will be displayed. If you're having technical issues or if you would like to ask a question to our faculty, please put your question in the question chat pane on the right-hand side of your screen. At the end of this webinar, a survey will be emailed to you within 1 to 2 days. We'd greatly appreciate it if you could fill it in for us and send it back. Finally, within 1 to 2 days, a certificate of attendance will be sent to you, as well as the recording of this evening's webinar. Again, if you want to submit questions, please submit the questions using the question chat pane on the right-hand side of your screen. I wrote a note there so you could see where you need to type in your questions to our faculty. So without further ado, I am going to pass the floor virtually to Dr. Goldberg.
Thank you so much, Roxanne. Hi, everybody, from the wonderful city of New York City, where I am right now. So let's go through the outline tonight, what our objectives are. One, we're going to review aging-associated alterations in epidermal function, which lead to xerosis and related pruritus and itching. We're going to review the challenges in preventing, treating, and maintaining mature skin associated with xerosis and pruritus. And lastly, we'll explore the benefits of maintaining or restoring a healthy skin barrier using skincare, specifically ceramide-containing skincare for mature skin individuals. So with that, we're going to bring up our first polling question. The incidence of xerosis in patients over the age of 83 is less than 50%, greater than 50%, less than 99%, greater than 99%, or approximately 25%. What do you think? So, less than 50%, none of you, that's correct. Greater than 50%, 67%, that's partially correct. Less than 99%, 0. And yes, most of you got it right. Greater than 99% of people over the age of 83 have pruritus in really all parts of the country, not just in the Northeast. So, really big problem. So that's what led to this poster that was just presented at the MOPD meeting associated with South Beach Symposium, February 9th to the 12th, 2023, in which we discussed promoting a healthy skin barrier using skincare in people with mature skin xerosis. And I'm going to go through the various parts of this poster and the discussion, and then Dr. Gold at the end will finish this as well. So how did we get to this publication? A panel of 7 dermatologists, Dr. Gold and I were included, convened for a meeting to review aspects of xerosis in mature skin, skin barrier changes, and nuances in the treatment and maintenance of mature skin using gentle cleansers and moisturizers. With that, from the selected literature, 13 statements were drafted, which underwent the panel's evaluation at a subsequent workshop, followed by a plenary discussion, and ultimately, as you'll see, 5 statements were adopted using evidence from literature coupled with panelists' opinions and their experiences. So 5 statements coming out of this. The statements discussed in the publication. Statement 1, and we'll review all these in detail. The exact etiology of xerosis, of course, is not entirely understood and likely depends on several genetic and environmental mechanisms. Statement 2, xerosis in older individuals is multifactorial and may include intrinsic age-related changes, which you can't do anything about, but also the use of diuretics, similar medications, systemic conditions, hypothyroidism, and overuse of heaters or air conditioners, depending where people live. Statement 3, aging-associated changes in epidermal function include a 30% reduction in total lipids in the stratum corneum relative to younger skin due to reduced epidermal lipid synthesis. And that's where the ceramides we're going to talk about come in. Statement 4, in aging skin, xerosis is significantly associated with pruritus. And lastly, statement 5, moisturizers containing urea, ceramides, and lactate have now shown benefits in promoting a healthy skin barrier structure and function in xerotic skin. Statement 1, the exact etiology of xerosis, as I said, is not entirely understood and likely depends on several genetic and environmental mechanisms. Let's go into that. Aging population and dermatologic changes. Today, most people can expect to live into the 60s and beyond. Every country in the world is experiencing growth in both the size and the proportion of older persons in the population. But aging beyond 50, whether we like it or not, causes several fundamental changes in the skin with significant and widespread dermatological implications. Skin conditions affect up to 70% of the aging population, and the most common, as we mentioned, are xerosis and its related pruritus and itching. So immature skin xerosis, of course, is very common. As I said, it affects over 50% of individuals over the age of 65. And to get to the question, the polling question, of advanced age with a mean age of 83.6, 99.1% do develop xerosis. The etiology of xerosis, not totally understood, likely depends on several genetic and environmental mechanisms, with the changes in keratinization process and lipid content in the stratum corneum as we all grow older. Xerosis, as we all know, is associated with pruritus and itching, mainly involving the extremities, and more prominent at low temperatures and humidity conditions. Mature skin xerosis in older people clearly affects their quality of life. Quality of life may be highly effective, and scratching can lead to secondary infections, ulcerations, and chronic wounds that are that much harder to treat. So we want to really try to stop that. Managing xerosis and maintaining moist skin are mandatory to prevent these complications, and moisturizers do represent the mainstay of treatment of xerosis and related pruritus in mature skin. So we look at younger skin versus older skin. You see a lot of these changes: epidermal atrophy, dermal atrophy, disorganization, loss of collagen fibers, reduced vascular tissue. All of these lead to xerosis. So, young versus mature skin. In mature skin, keratinocyte renewal slows down, apoptosis increases. Along with the gradual degeneration of skin innervation also, there's a heat imbalance and cold tolerance deteriorates. So older people tend not to handle cold weather very well. Skin barrier dysfunction may lead to increased water loss, transepidermal water loss. The number and function of sebaceous glands decrease. They, of course, produce oil. Less of them leads to xerosis. Xerosis then leads to increased vulnerability of the skin with more marked pruritus. And pruritus, it's a never-ending circle, leads to scratching, leads to more pruritus, leads to secondary lesions, excoriations, and erosions. That's statement 1. Statement 2, xerosis in older individuals is a multifactorial process and includes intrinsic age-related changes, use of diuretics, a variety of cardiac issues, other similar medications, a whole variety of systemic conditions which lead to dryness, hypothyroidism, and certainly because older people tend to be colder, the overuse of heaters, and then when it gets warmer, they don't handle the heat well, so they need more air conditioners. So, process which is multifactorial. Xerosis is characterized by a decreased quantity and quality of lipids and or moisturizing factors, and is generally diagnosed on clinical presentation. When you see that picture, all of us know that is xerosis. Called xerosis, asteatotic eczema, but it's clearly xerosis. So we want to distinguish between constitutional xerosis and xerosis due to a variety of dermatoses, such as atopic dermatitis, psoriasis, or exogenous factors. And of course, xerosis occurs as we get older, but it also may be due to systemic diseases, such as diabetes, kidney, liver, biliary issues, infections, hormonal changes, or even triggered by a variety of medications. Intrinsic aging of the skin, of course, is fundamentally an unsustainable process. Its speed depends on individuals, mainly genetic factors, which we have no control over. Intrinsic aging affects the skin of the entire body, including sun-protected areas. So extrinsic aging is more extrinsic aging is more common on lower legs, intrinsic aging everywhere. And intrinsic aging is primarily characterized by atrophy, as the number of skin cells and the quality of the extracellular matrix decreases. With that, the number of blood vessels and nerves in the skin decreases, or the quality deteriorates, and signs of intrinsic aging typically present at around 50 to 60. Women do develop these signs a little bit earlier, usually due to a decrease in estrogen that's associated with menopause. So when you look at all the different factors which contribute to xerosis, there are many. Obviously, a whole variety of dermatologic diseases, intrinsic factors, and including internal diseases, many of which are listed here, psychiatric disorders. We know obsessive skin cleansing can also lead to a problem. Dietary disorders can lead to xerosis and a whole variety of causes, and then medication related. So you really need to think about what the causes of xerosis may be. And then there's the effect of exposure to what we call exposome factors. Exposure to exposome factors triggers the age-associated microenvironment. And this is something we're really beginning to look at now. Chronic exposure to reactive oxygen species triggers the skin aging process, which includes increased production of MMPs. Those are substances that lead to ECM breakdown, collagen fibril fragmentation, reduced production of collagen, creation of a pro-inflammatory microenvironment. This is all going on in the substructure as we see the exposure to exposome factors. As a result, dermal structure and mechanical integrity is weakened. And you can go through that diagram and you can see all the different factors as you associate exposome factors and lead to the increased pH, which leads to a whole cascade of events, which ultimately lead to xerosis. But notice in there's decrease in ceramides, and that's what we're going to get to later. That was statement 2. Statement 3, remember there are 5 statements. Statement 3, aging-associated changes in epidermal function include a 30% reduction in the total lipids in the stratum corneum relative to younger skin, and that's due to reduced epidermal lipid synthesis. So aging-associated changes in the epidermal function. Studies have shown that the aged stratum corneum, as I said, shows a greater than 30% reduction in total lipid content compared to younger skin due to reduced epidermal lipid synthesis, particularly in cholesterol synthesis, both under the basal layer and in other areas, and under basal conditions and after barrier disruption. So if you look at this, you see there's a decreased permeability barrier. As I said, there's an increased pH in the skin. There's decreased hydration of the subcutaneous tissue, whole variety of factors, but lipids become a part of this. And as you decrease those lipids, you end up with pruritus, cutaneous inflammation, a whole variety of circulating levels of cytokine and inflammation results. So a terrific and long-winded cascade but ceramides and lipids play a part of that. There is also an increase in the microbiome diversity with age, something that I never thought about 30 years ago. But increased microbiome diversity may be due, what causes it? It's due to reduction in propionibacterium bacterium with age. You know, we associate high propionibacterium bacterium acne with younger people. And as propionibacterium bacterium decrease with age, you allow other competing bacteria to grow. And in older subjects, researchers have identified 38 species, including many oral bacteria, that are significantly differentiated into the younger and older age groups. The authors of this study concluded that the skin microbiome could be used as a new indicator to quantify skin age, irrespective of chronological age. So you look at the things that change with age, it's porphyrins on the cheek and nose, sebum secretion. We know about hair color, forehead porphyrins, and that can be associated with different ethnicities. Smoking is certainly not something good. Excess weight is not something good. And you can see age also increases these. So these variables are found to be significantly correlated with the microbiome variation. Number 4, in aging skin, xerosis is significantly associated with pruritus, with itching. Age-dependent changes in the stratum corneum barrier function are obvious. What happens? You see changes in transepidermal water loss. That affects barrier function. It decreases on different areas. The subcutaneous thickness is an issue. Lipid compactness decreases on exposed arm skin and even protected arm skin. There are changes in lipids. They decrease over the entire body, although they seem to stay pretty constant on the face. You see changes in cholesterol in the skin, ceramides, total water, and moisturization. So as I said, xerosis does lead to pruritus. Yeah, this slide says may, but it clearly does. Changes in mature skin structure and its ability to regenerate along with the cumulative effects of the environment do inhibit the subcutaneous barrier function and hydration. These changes make individuals more susceptible to the entry of irritants. So whatever they apply to their skin becomes more irritating, and whatever allergen they're associated to becomes more of a problem. And that leads to inflammation, pruritus, xerosis, more pruritus, more inflammation, and all the secondary changes we've talked about. In fact, a cross-sectional study, which included 756 patients aged 65 and older, reported a prevalence of xerosis of 56%, age 65 and older. Of these patients, 9% had moderate to severe xerosis associated with a significant disease burden, including pruritus and feelings of very dry or unbearably dry skin. Another cross-sectional study of a huge number of people, 11,730, showed that the prevalence of chronic pruritus was 20.3% as we start getting older, 60 to 70. And I already gave you the numbers in the 80-year-old group. The large study demonstrated significant xerosis-associated risk factors for pruritus, including older age, female sex because of hormonal changes, atopic dermatitis inherently, or concomitant treatment that also can lead to xerosis because of various medications. So pruritus in mature skin clearly is associated with xerosis. And in fact, pruritus is the most common skin aging disorder. You know, we think about skin cancer all the time, which obviously is more common as people get older. But pruritus is the most common skin aging disorder. Studies have shown that the incidence of pruritus can vary between 11% and 78%, and again, gets higher and higher as we get older. And then there are all these additional causes of pruritus besides inherent xerosis, and those are comorbidities such as renal failure, cholestasis, systemic infections, diabetes, liver failure, malignancies, and then a variety of hematologic disorders, which unfortunately are more common as people age. So the other factors influencing xerosis, environmental factors, we talked about this: cold weather, low humidity, indoor heat, intense exposure to sunlight. Occupational factors are also there. You know, people who have their hands wet We know that they dry out more, or any kind of wet work, which leads to contact with irritant or occupational substances. Who do you see this in? Hairdressers, construction, metal workers, nursing staff, housekeeping, me, because I'm constantly washing my hands, changing gloves. And then skin cleansing and washing, those who take frequently long hot showers or baths, who use bar soaps such as alkaline soaps or cleansing agents, all of them suffer from xerosis. So here you can see xerosis on lower leg in A, mature skin xerosis and scaling above the knee with picture B, mature skin xerosis with erythema, and then maturing skin xerosis, scaling and fissures on the heel. Just such common conditions that we all see virtually every day in our offices. So that leads to polling question 2. And with that, I'm going to introduce Michael Gold, who needs virtually no introduction, who's now going to handle the second part of this talk. Michael, it's all yours.
Thank you, David, and I hope everybody can hear me. And I do want to put this polling question up. This is: the following ingredients have been shown efficacious in promoting a healthy barrier and function in healthy skin. Please select 1: urea, hyaluronic acid, lactate, ceramides, or all. Obviously, we think of urea, if you're, as the older dermatologists like to think of urea, but I think, we know that these all work, and the ceramides are a major part of what we're going to talk about. And I think one of the things as David pointed out, is the massive changes that we've seen over time, with the moisturizers that we have today and how useful they are. So, and I think I have control of the, okay, so now it's going way too quick. So I'm going to go back for a second now that I have control. Okay, so that was David's, right? I need my team to, there you go. Okay, so, all right. So this was David's, right?
Let's just see. Yep.
Get me back to you all take over, and I'm going to say next slide.
Okay, perfect.
All right, so moisturizers containing urea, ceramides, and lactate have shown benefits in promoting a healthy skin barrier structure and function. And I think that's one of the things that we've all really been taught recently, and the clinicals that we have indicated that this is what we need to be thinking of. And I think what David mentioned before we go on to the next slide, what we've learned is we've all seen this for years in our practices. And having elderly parents who recently passed away, I dealt with dry skin all the time, but as David said, we're washing our hands every day, more probably now than ever. So we see it all the time. So we need these correct moisturizers. So I think that's really important. So we need to maintain the healthy skin barrier as much as we can, not only for our elderly, more mature, and I'm part of that more mature world now, but for everybody, but specifically in that mature population. Next slide. All right, so again, I think what we know is that there's a big permeability function of the, that we see with the healthy skin barrier. And then as we know that when you get a defective or as you age, things happen, we get more transepidermal water loss, increasing our skin sensitivity to irritants and allergens, altered and loosened lipid arrangements. All these things are happening as we age, again, through what David said, this intrinsic, environmental effect on the barrier. And it's incumbent upon us to deal with this with our patients. And again, if you do any kind of dermatology, you see this daily. Next slide. So promoting a healthy skin barrier is the goal. We want the moisturizers to contain emollients to smooth the skin, and that means either glycerin or oils with butter in it. We want humectants to hydrate the skin, and again, most of us would normally think of urea or some natural moisturizing factors. And then we want light occlusives to trap that moisture, whether it's silicones or petrolatum. Moisturizers can be further optimized with, again, the addition of physiologic lipids to restore that barrier function. And that's where the ceramides, cholesterol, free fatty acids come into play. So we can use these physiologic lipids on top of what we already have to give us a better effect. Next slide. So ceramide-containing moisturizers help restore the skin barrier. So again, stratum-coordinated lipids such as ceramide-containing skincare with a gentle cleanser and moisturizer combat skin cirrhosis and may reduce pruritus. Again, the drier the skin gets, the more itchy they get, and the cycle just gets worse and worse. So if we can combine that by having, essential ceramides, the right emollients, the right humectives, the right occlusive agents, we can try to at least get the barrier back to where it should be, which will allow our patients to have a better quality of life. Next slide. So again, when we look at some of the general measures we think about for mature skin-associated xerosis, we want skin cleansing, contact with water. Again, I think this is pretty common what we tell our kids that we treat with atopic dermatitis, but I'm not sure we always do it with our elderly patients or more mature patients. We don't mind them taking a full body bath or getting in the shower, but we want it to be lukewarm. We want it in and out, mild non-alkaline soaps. We want them to pat their skin dry, not rub everything to death, which older people like to do, as do the kids with atopic dermatitis. When we're cleansing the face, again, skincare with products that are low in fragrances and allergens. We want no shampoo on the face. We want, again, people sometimes get neurotic about how many times they need to clean their skin, no more than twice. Hands and feet, as avoid contact with water, soap, and detergents. And again, everything should be fragrance-free and allergen-free. Clothing is also important. Again, cotton, not too tight. Wool clothing is drying, so can dry the skin, especially on the hands and feet, especially gloves. In the winter, cotton gloves can be as inner lining. Diet, avoid citrus foods, very hot and spicy foods, large quantities of hot drink and alcohol. Obviously, all of this in moderation is not going to hurt anybody, but as you get older, you got to be careful because this stuff is going to promote more dry skin. Climate, again, as you get older, you're always cold. So at least that's my family trait for history or whatever. So you want to make sure you're maintaining an appropriate ambient temperature around you. Don't go out in the sun. If you do, sunscreens with moisturizers and all that kind of stuff. And again, avoid agitation, tension, and stress. Easier said than done for lots of people, but that'll help if they have this significant mature skin associated xerosis. Next slide. All right, so this slide is really busy. So there are different kinds of types and effects of moisturizers, from the natural moisturizing factor to humectants, and which are these are the remoisturizing. That you see the key ingredients here: urea, lactic acid, glycerol, and hyaluronic acid. There are film-forming hydrocarbon mixtures, silicone oils. These are, to me, what keeps the skin sort of feeling good. Then you have lipid replenishing, which are the barriers, which contain our ceramides and sterols and cholesterol derivatives, or naturally occurring oils and so forth. Really something important in today's world. So again, we'll focus on that. There are skin soothing moisturizers that contain chalcone and other things, and that's good. And then you have antipyretics, and I think the antipyretics do play a role. And again, there's some anti-itch lotions that have ceramides in it that are sort of the mainstay of what I recommend to a lot of my patients. I think it works incredibly well. And the nice thing about these anti-itch lotions is that they can use them often during the course of the day. So again, whether you like lotions or creams, you can decide how best to do that. But adding these ceramides have really been a game changer. Next slide. Can I get the next slide? So again, we're going to go through some of these clinical studies. We'll go through 5. These are for the first 3. We've already shared a little bit about Zoe Dralos' study. 53 healthy women, randomized investigator, blinded split leg study, a ceramide-containing cleanser and moisturizer. Again, looking at the skin hydration, signs of xerosis, and the results. They improved skin water content through corneometry, reduction in subject perceived sensory discomfort, and the dermatologist were able to show signs of improvement in things that cause skin dryness. And they found this for about 48 hours continued after the moisturizer was discontinued. The second study, published by Danby et al., mature skin, 2 cohorts. They had cohort 1 test product on the forearm, no treatment on the other. Cohort 2 testimonial versus a control, and then a young adult, 6 young adults. And you see their emollient-containing cream had urea, ceramide, and lactate. And again, the testimonial showed significantly better and longer lasting results. We're going to come into all these in a little more detail. The third study, mature xerosis in 20 patients, 12 males, 8 females, again, a mature population, 62 to 82, written a couple years ago, again, using 10% urea cream. And again, they found improvement in everything that they were looking at that was statistically significant. So next slide. All right, so this was the published paper that Zoe published a couple years ago, 4-week single center controlled study, CeraVe moisturizing cream twice daily on the lower leg, the other leg untreated. They made assessments at baseline immediately, day 3 and week 4. They did corneometry and other things and subject evaluations. Next slide. And again, kudos for doing studies like this, because when we were residents and young dermatologists, nobody really did a lot of studies on moisturizers. So again, when you look at the improvements in clinical signs of dry skin, that was maintained after 48 hours. So you see the baseline, and then you see here the end of the study, 80% improvement, and then that maintained itself for 2 more days, which I think is very impressive. Next slide. And twice daily use resulted in a 14% increase in the cholesterol levels and 11% increase in free fatty acids versus baseline. And again, that maintained itself after the withdrawal. Now, again, I think that's important for study-wise. Our patients we're gonna recommend in real world to keep using this on a daily basis. Next slide. But I think what it shows also is if you skip a day, it's okay. But again, we want these people using every day. Twice daily use for 4 weeks. Again, you see here this when we put the graphs on, you see this increase in cholesterol and increase in free fatty acids versus baseline. Next slide. And again, when you look at some of the clinical photographs, baseline, dry skin, xerosis, you can see the improvement really by day 3, but it continues all the way 4 weeks and 48 hours past. So I think that's really, really impressive. The skin looks better, it's more radiant, the patient's not itching anymore, they're not dry, and they're not gonna have as many associated problems as other people may have. Next slide. The second study, again, was using urea, ceramide, lactate on skin barrier structure and function in mature skin. Again, 28 days, 2 cohorts, really 3 cohorts. Test product on the forearm, none on the other. test emollient versus control, and then again 6 young adults to see how it worked. And the control you can see there was Aquamol, and the test emollient was some we call Balneum cream, which is a European. See the ingredients. The control really water and some paraffin.
Dr. Gold, I think
The test product, Urea, Ceramide, some glycine products. Next slide. Can you hear me?
now we can hear you.
Can you hear me, Roxanne?
Yep,
Okay,
we
sorry.
can hear you.
All right, so this, because I see myself talking, so I think I'm stuck. Okay, so this, again, this effect of the emollient-containing urea, ceramide, and lactate, and what you see here, 28 days treatment, the significant improvement that was seen in the stratum corneum, in the integrity of the stratum corneum, in the improvement in between the test emollient compared to the untreated control. Next slide. Again, looking at this, the conclusions of this study, that the test emollient significantly hydrated the skin to a greater extent and for a longer period compared to an emollient that contained no skin moisturizing factors. So just having an emollient isn't enough. You need to have an emollient that has things in it that is like
Dr. Gold?
slide, please. Can I have the next slide, Roxanne?
Yep.
All right, the third study, again, looking at 20 patients with moderate to severe cirrhosis of the upper and lower leg, twice daily cream, urea, 10% urea cream, evaluation at baseline, day 7 and day 14. They use the scores that are shown here, looking at clinically the evaluation, itch measured by a visual analog scale, and dermoscopy, which I think is very interesting. But you can see what the scales were here. Next slide. And again, the results, baseline, 7 days end of treatment. The clinical evaluation, again, went from 2.5 to 0.25. The itch went down from 2.1 to 0.6. Dermoscopy, which is the scaling, you see the improvement here. And just the overall, when you add them up, everything went down to very acceptable levels. Next slide. And when you look at the clinical pictures, I think, again, that shows the difference here. How well, and again, the bottom is the dermoscopy, how well the skin gets back into shape, and how, again, these are patients that are going to thank you 1,000 times over for recommending the right skincare. Next slide. And again, here's another patient here, same kind of thing. You see that improvement in the skin, and then dermoscopy, you see the improvements here. Next. So 2 more studies really quick. So again, 2022, Kim et al. Looking at 52 patients with moderate to severe cirrhosis. It was an investigator-blind and random controlled clinical trial, 39 with a mild cleanser and moisturizer for 2 weeks. A controlled group just had a mild cleanser without a moisturizer. Total clinical score, looking at everything that you could look at, was done. And the results at 2 weeks, the treatment group showed more improvement in the improvement in dry skin, in the itching as compared to the control group, and that was very impressive. Again, in the 5th study, Felipe et al. Was presented last year's Academy, not this past one, but the one before. 30 patients, again, clinical evaluation, ceramide-containing cleanser and moisturizer. And if you look at the results at day 28, the mean physician scores decreased significantly, 3.1 to 0.6 or 82%, discomfort to dryness 93%, fissures 97%. So that's what you want to see, and that's what we're able to demonstrate in that study. Next slide. And again, here is the paper that Felipe presented at the AAD last year. And again, when you look at this, the conclusions with this once daily ceramide-containing cleanser and twice daily ceramide-containing moisturizer cream improve signs and symptoms of senile cirrhosis. And that's, again, the goal of what we're trying to do. Next slide. So again, this was this elderly patient, 30 men and women. Subjects used this cleanser. Again, everything worked really well. Next slide. I sort of went over all this already in this thing. But again, the inclusion criteria are shown here. There was a balance, that there was 63% of the patients were men, but that's considered balanced. Legs and feet are the main areas, but other areas were included. Next. But if you look at the improvement in the quality of life, so that is very impressive. And again, you see everything that is there, and we're dealing with all of this with all of our patients. As far as you look at the different medicines that were involved in this study, all of these cause dryness. So we were able to see positive results despite the fact that these patients were on these kind of medicines. And I always tell my patients, no matter what, they're on medicines, I'm not going to tell them to stop their medicine. I may call their internist or primary care doctor to discuss it, but we're dermatologists. We need to work around their medicines. So I think by having the proper ceramide-containing moisturizers and cleansers, we can work around those problems. Next. All right, improving the quality of life. Again, when you look at the roughness and or desquamation, 82% improvement, discomfort, 93%, and fissures, if they had them, decreased by 97%. Next slide. Again, when we look at roughness and scaling, that resolved in 50% of the patients. Discomfort went away in 80%, and again, the fissures went away in 97%. Next. And again, the clinical pictures speak for themselves. I mean, if you're looking at patient 6 on the right, dry skin, dry heels, the one on the left, patient 4 with on the legs. I mean, if you're over 60, this is not uncommon, right? And so we have to be able to get our patients using the proper things to make them better. And I think, showing these pictures will be very helpful to your patients. So you do what we ask you to do, you should get better. Next slide. Again, we showed all this before. At the bottom, quality of life improved 77%, no longer feeling embarrassed. Again, I think that one of the worst things is, again, these patients are sitting there like in a waiting room in our office or somewhere in a restaurant, and they're scratching their legs and feet. How many times have we seen that? And again, with the right things, we can avoid that. Next slide. All right, so the conclusions for this. The development of xerosis in mature skin involves several genetic and environmental mechanisms that David covered really well. Skincare is frequently lacking or overlooked as part of the skin treatment for this population. Absolutely. I can't tell you how many of my patients come in on a daily basis, and we always ask, what is your daily skincare routine? Well, I use soap. Okay, what kind of soap? I use cream. What kind of cream? I mean, they're not appropriate 90% of the time, and that's why we actually in our clinic spend a lot of time educating about ceramide-containing cleansers, lotions, and creams. Skincare, including gentle cleansers and moisturizers, has reduced xerosis and pruritus in mature skin individuals. Next slide. All right, I think we have, next slide is question and answers, right?
If you want to submit any questions,
David Goldberg.
Yep. If you want to submit any questions, please use the question chat pane on the right-hand side of your screen. And if you think of any additional questions for our faculty after the webinar, you can always send them at info@rbcconsultants.com. We'd like to thank our sponsor, again, CeraVe, for making this educational event possible. And remember, we're going to have another Skin Chat on April 11th in terms of ceramide-containing skincare, different stages of life with Dr. Andrew Alexis, Hilary Baldwin, and Lauren Schackner. So let's go
So we were the B team leading up to this A team, right?
Oh, how true.
No. So we have a couple of questions from the audience. We hear about the microbiome more and more affecting our skin. Please give us some insights and understanding here as to how it plays a role in xerosis.
So I think I'll handle that one, at least in the beginning. I mean, it's become very clear that there is this GI skin connection. You know, we don't understand it totally, but we know that kids with atopic dermatitis, sometimes what they eat affects their skin. And that's increasingly being seen in older people as well, in fact, more commonly in older people. So the exact mechanism, I don't think anybody understands, but this, which I think would have been considered hocus pocus 20 years ago, is real life medicine today. And there's something that goes on as the gut gets older and as the skin gets older, that communication, which really starts from day one. When you think about babies being born, they're breastfed by their mothers, and sometimes whether they have colic or not really depends on what their mothers are eating. So there's clearly a connection to between the gut and the rest of the body. So no surprise with xerosis as we get older.
And I think we're going to learn so much more about the microbiome and its role here in the next few years. But I think David's right. This is a major thing that we need to consider.
So keratoderma climatericum is a common problem. What is your favorite moisturizer recommendation for this difficult condition?
Ceramide.
Are we allowed to use brand names or no?
I mean, CeraVe
Yes.
obviously works very well for this because of the ceramides in it. There's no doubt about that.
Right. And the nice thing about CeraVe and all that there's different kinds. So you can use ceramide, that have salicylic acid. You can have, other things that are in there that really help the skin, especially in these really chronic keratoderma type conditions.
So what should you be looking for in a cleanser, and any suggestions of brands?
I'll start. I mean, I think one of the things we always say is soapless cleansers. And so, yeah, I mean, again, the CeraVe line of cleansers, whether it's hydrating facial cleanser, it's just called hydrating cleanser now. And they have a hydrating body cleanser, and then they have a soothing cleansers, which I recommend all three of them like 20 times a day. So I think, that's the go-to in my office.
And I made the comment in my portion of the talk, Roxanne, about the pH of the skin. One of the reasons why we know that bar soaps are terrible for the skin is because they have a totally different impact on the skin than liquid soaps or lotion soaps. And so that always is going to be a factor as well.
And there was one soap when we were growing up that was 99% pure, and they left off the word soap. And so that became the most popular soap ever sold at that period of time because it was 99% pure. But what people didn't realize, if you had sensitive skin or mature xerosis, it was actually drying the heck out of you.
Yeah.
Are coconut oil, shea butter, and olive oil good moisturizing agents for patients who want natural moisturizing oils?
Well, first of all, the concept of natural is always fascinating because, petroleum products, gasoline for that matter, is natural. So natural doesn't mean anything. And I find that I have patients who come in all the time who use coconut oils, shea oils, things of that sort, and then become sensitized to it. So, they're not necessarily the answer by any means.
I agree. But again, I always tell people, you can use what you like, and when it doesn't work, you're going to come and listen to what we recommend, because again, we have the science behind it. And as I said in my talk, 20 years ago, 25 years ago, how many papers were there on cleansers and lotions? I mean, not many. And now we have one after the other, because we're interested in dry skin, aging skin. How do we make the patients feel better? So I think, again, I try to educate the best I can.
Well, this is the difference between the Google search, which leads to shea butters, coconut oils, and the science, which leads to CeraVe type ceramides.
So thank you for a great review. Any tips for actinic purpura in older patients?
So actinic purpura, so senile purpura in itself is not necessarily a xerotic condition, because obviously it's fragile skin that leads to that purpura. But invariably, patients with senile purpura have xerotic skin. I mean, they have thin skin, it's itchy. And so some of senile purpura is just intrinsic aging, and you can't do a thing about it. But some of senile purpura is because of the scratching that occurs because of xerosis. And so the answer to that is appropriate skincare.
Yeah, and I actually agree 100%. And I like using, because these people are really dry if you get into it. So I like using the ceramide-containing moisturizers, creams, or over lotions. And I'm a lotion guy, but I like the cream in this condition. And then sometimes I actually look for some barrier creams. Not that I know they do a lot, but again, it gives me another added thing to help with their dry skin. And I think that's something that I've always been using, or I've been using more and more lately.
How often should one moisturize the skin?
All day.
Yeah, the more the better. Certainly at least twice a day, morning and night, but the more the better. And if you're going to end up, if you end up dry skin because of water, I'm sorry, Michael, go ahead.
No, go ahead.
No, I was gonna say, if you're washing your hands constantly, you have to moisturize them constantly. Practically legs and things of that sort, at least twice a day.
I'm not sure if you answered this question, but does soaps versus cleansers, is there a difference for our patients in the real world?
Michael?
Yeah, I'm here. Okay. I tell people to use it all day long.
Yeah, but they're asking about soaps versus cleansers.
So I only recommend, again, I sort of froze for a minute. I only recommend soapless cleansers. All right. I don't like having said that, all right, I actually recommend, there's a foaming cleansing bar that I love. Okay. And I think for the right guy, mainly the young guy who likes to be in the shower more than he takes, whatever, I like the foaming cleansing bar.
Dr. Goldberg?
Yeah, well, I think, part of this has to do with the nomenclature and the semantics of this. We think of a soap as a bar, and that's inherently not good. We think of a soap-less detergent as being a liquid, which is better. But obviously, there's some crossover, and I think Michael made that point. But the more soap, the more more alkaline, the more you're going to dry out, and the more you're going to itch.
So that is the time that we have together with Dr. Golden Goldberg. Again, thank you so much for a great review, clinically practical presentation for mature skin xerosis. And thank you all for joining us this evening. Good night.
Have a great night, everybody.
Good night.